You're listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, Kelsey Coons, and Gerard Cuomo. All are current EMS providers and educators with a combined 30 years experience. Each month, we discuss EMS news, medical science, and review actual EMS calls, bringing many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome everyone to the Medic Materials Podcast. My name is Mike Turek. I'm here with Gerard, Kelsey, and Emily as always. It is June 1st and it is finally freaking hot in New York.
Thank Jesus.
No, thank Jesus.
Yes, no. Give me hot every day.
No, it's disgustingly disgusting.
Still in a long sleeve
Outside.
shirt. It's not hot enough.
No, it's disgusting. Did you just paint your house? It's disgusting.
Did you?
Yeah.
Or did
you
someone
not?
else?
No. I've been out there for like 5 days. Thank you very much.
It does look good.
Yeah, I know.
It just got rained on.
That's okay.
So
Yeah.
good I didn't even notice.
Yeah, so good. He didn't even notice. Like, go from
Really?
one crazy color to the polar opposite.
Yeah.
Man didn't notice.
Yeah, I walked in, he's like, yeah, we were painting out there, and blah, blah, blah. Like, oh,
I think
Where?
I
think it looks really nice.
That scares me. That like, could you miss like a arterial bleed and you're like squirting out? Oh yeah, I don't know what I missed, but he died.
Wait, there was?
yeah, I didn't realize that.
Where was
I
that?
know I didn't put freaking ketchup on my fries.
You know why, though? It's because you didn't pull up. When you normally park and you pull up.
Right.
That's why.
Yeah, that's what it was.
I'll defend him on that.
Thank you.
Okay.
I appreciate
All
that.
right. Defense taken. But it is a cool day for other reasons. Kelsey, you were saying that your dad actually now listens to the show, which is kind of
Hi,
cool.
Pops.
Hi, Dad.
And I will say it is my dad's birthday today.
Oh,
and,
happy birthday.
And guess what? He won't hear that because he's not proud of
I
this
know.
show. So it's quite okay. But I still wanted to wish him a happy birthday. So as we move on, he says we're unprofessional, but that's coming from a very, white collar business background. And I could totally see where he would be thinking that. So I'm just,
There's a lot of things I would
gonna
use to
mosey
describe
on.
us for. Professional's probably not one of them.
yeah,
probably.
exactly.
White collar is also
Yeah,
definitely
no,
not
definitely
one
not.
of them.
But in reflection of birthdays, I did just kind of want to go off on a tangent here. As a lot of people know, it was my birthday 2 weeks ago. And I kind of had a time to reflect on the year that it's been literally just over a year that this whole brand, Medic Materials, has started. So I launched the first video March 4th of 2020. There was a 2-month gap between the first and the second, and then it's been a May 15th. I launched, the rest of all of the videos, and it's been a year now, and it's kind of like a surreal feeling. The success in this last year and just the amount of growth. Like, we all hear the stories that people are listening to the show and they're watching the videos, and old instructors are like, dude, your shit's really, really good. And the podcast with everybody is really, really good. And the analytics don't lie either. Just in the last month, 33,000 people have seen at least a thumbnail of ours on YouTube.
Wow, that's insane.
Right? 16,000 views we've hit on YouTube.
Please, no paparazzi.
No, we have enough fans.
No
Within the year, we gained organically over 460 subscribers on YouTube. There's over 550 people that like the Facebook page. There's now over 600 that like the Facebook group. And we're
exciting.
This show, just the podcast alone, is closing in on 2,000 downloads.
Oh my God.
In
I
total.
get like a little cheering down.
Wow.
Yeah, seriously.
Woo!
I got you.
It literally is just a surreal feeling because I didn't have like this whole plan. I just said, I want to teach EMTs and paramedics, and I want to do it in a way that not a lot of people are doing it. And that was on YouTube. And there's a lot of stuff on YouTube, but it's all old, or it's all very condescending, or it's for nurses and doctors and not us. And I felt like there was a niche there, and I kind of just went after it. And I couldn't do it without the three of you guys. It has been awesome to just sit down here and banter with you guys and do this show. I feel like if it wasn't for our playing off of each other, this show would not be successful. If it wasn't for Gerard coming back,
Honestly.
this show would not have been
Very
successful.
true.
Yes.
I am
Yes.
going to remind him that he is amazing every
Yes.
single time that he says, it's not me.
Baloney. You saw the numbers.
We all love you.
Just your show
you.
tunes. It's your show tunes. Everyone wants to hear
That
you
is true.
sing.
That is true.
You are the comic relief of this show.
That is
Yes,
true.
I've noticed,
100%.
like,
Yeah.
there's always more laughs when Gerard is
Yes.
here. It is 100% true. So
Awkward without you.
it is. You talk the second most amount on this show. It's me, then you.
That's probably not a good thing.
But it is. But sincerely, this show wouldn't be a success without the three of you guys. And I want to say thank you. And I just want to say thank you to everyone who listens and is a subscriber and a follower. It is absolutely amazing what organically we've done in the past year. And it's going to continue to grow because I just see more and more feedback. The stories come in every week when we get together. Oh, someone else was talking to me and this, that, the other thing. So, Kelsey, let's go into your rig check. And just so you know, I think the four of us are going to be in the dog thing,
Yes.
right? We're going to be there. So,
But I want to throw a flag on the play real quick.
okay. Yellow or red?
We'll go with yellow.
Okay.
We'll go with yellow.
Carry on.
Okay. So there's another reason why things are probably going to be getting better and better. Because something else happened this past month with Mr. Turek that he's
Got
not-
old?
I did get old.
He did get old, but
He's been old.
you
Let's
also
be real.
accomplished something, didn't you?
I did.
Something big.
Well, it's
Something
not that
huge.
Something
Yes, it
amazing.
is.
Something that's been 3 years in the making.
Yeah.
It has been 3 years, but most people already know if they're on the Facebook page and stuff like
Well,
that.
good for them.
But I did.
It doesn't make it any less exciting.
That's true. That's true.
None of you count.
And if you
Except
do, you
for
get
all
to
of you.
hear it again.
That is true, Gerard. Thank you. I did. I did finally get my CIC, my actual instructor
Course in service.
certification. So hopefully, I won't just be an intern teaching classes. It'll actually be like me teaching classes.
Absolutely.
So
God, that's
that
awesome.
is.
The best class.
Yeah, that's awesome.
I have a lot of refreshers that are going to be like, hey, I'm going to show up and you're going to teach me from the start.
From everything.
Yeah.
All over.
All over. There's actually a few of them that have reached out already and been like, I will take your class over again. Why? Don't do it. But yeah.
I'll take your class. Not over again. I'll just take your class.
Me and Emily would be in the
You
back.
just
I'm
wanna,
ready.
You just want to laugh at how I teach because I yell and I'm
I
animated.
love
and
the
I
way
throw,
you teach.
I throw my hands around and I jump around.
Are you
And
kidding? I would fail
Gesticulates.
every single scenario of yours.
they're fun.
I know.
They're
That's
so much fun. But
Yes,
you know
they are.
some of them, so
I know.
it's not like you could like go into them and
I'd
be like,
still
I'm
probably
gonna rock
fail
this.
it.
Yeah. No, you wouldn't. You'd rock it.
Yo, Mr. Tourniquet would have been dead.
That's because nobody cares
And I
about the cop.
still would have missed that. You could give that to me tomorrow. I would probably still
I
miss
think,
it.
I think you can give that to probably anybody. And very, very few would have picked up on that.
Yeah.
But it was, oh my God, I'm going to use a Star Trek term. All right.
I
Nerd
love it.
alert.
Nerd alert. I'm all ears.
It was the Kobayashi Maru.
Oh,
That's it.
Love it.
It's the no-win scenario.
it is.
I don't. Yeah.
So catch 22.
But Kirk won.
Stop being so young.
Because he
I know he cheated.
he cheated.
I know. I get it.
But no, he reprogrammed the simulation.
Right.
So
We're
I don't-
nerding. It's okay.
we
it's
could probably
it's
reprogram Justin.
He
Medic
did so
materials.
good. He did so good. But anyway, Kelsey, let's get with your rig check so we can finally get on with the really awesome scenario that we're going, or not scenario, but call review that we're going to do today. The ending is somewhat mind blowing.
Kind of fun.
So I hope that I see some jaw droppage
Mine
and being
better
like,
be blown.
no,
I already feel like
fuck this.
Right? There's just like this build up, and I'm gonna get to the end. We're just gonna be like,
That was it?
Oh no.
Oh no.
Oh
it's
no.
pretty great.
No. This is cool. Just
Okay,
you
what?
wait. Toby.
What? You stubbed your toe?
Okay, guys, so for today's break check, we are asking you to go donate to Operation At Ease on the Medic Materials Facebook page.
Do it.
If you don't know what Operation At Ease is, check out our May 1st episode. We have surpassed our $200 goal, but we want to keep donating because it is such a great cause. If you're looking for another way to donate to Operation At Ease and help out, they are doing a dog wash fundraiser at Wagtown Dog Grooming. It takes place on June 20th from 10 a.m. to 5 p.m. So all of you dog dads out there can spend Father's Day with your pups helping out a great cause.
And I must break in here. All 4 of us will be there. So if
And
you
Cooper.
want to
And
actually
And
like
Shadow.
meet us,
Yes.
there you go.
Yeah.
We will be meeting people who come up and be
Hanging
like,
out.
"You're the podcast people."
My dog will
Yes.
not be participating. She barely handled the hose down in the backyard I
Yeah,
gave her the other day.
I might bring Rebel, but he's not getting a wash.
I kind of want to bring my cat. Here, watch this. I got into something foul the other day.
And today we would like to shout out our listeners in Tennessee and Brazil.
Woo!
Obrigado, Brazil.
So cool. It's so cool seeing like the international reach.
I know, isn't it?
It's
Yeah, it
really,
is.
really
It's
awesome.
kind of crazy.
Like I said, now we gotta get the Zulus in on it.
Seriously.
South
not
Africans, where you at?
one
Where you at?
not one person is downloaded in South Africa. Like
Bastards.
So
Yeah,
we're missing,
seriously.
I'm assuming Africa and Antarctica, and then we'll have
yeah. Yep.
Yeah, we got down under.
Yep.
Yeah.
Mm-hmm.
Good day.
Good eye.
We should go
Bostis.
market.
Hmm?
Let's go on a road trip. Well, not a road trip, but
How would you like to
Let's go on a
road
trip.
We should.
to market.
It'd be interesting to take the podcast on the road.
Tax
Right?
write-off.
We should do like a whole
A meet and greet?
series of like meet and greets.
That would be cool.
Oh
That'd be
my
cool.
god, that would be awesome.
Like we could do like what like Free Beer and Hot Wings does. They like broadcast from inside of like a bar, but we'll do the inside of like an ambulance bay
oh, let's do it.
and like meet and greet.
Or how about we do it from inside of a bar?
Yeah, I was gonna say. I mean, I'm not against the
Most
bar.
ambulance bays are bars, so at least the Mollies have booze. But something to think
not a
about
bad
as
idea.
we grow the show. So let's get into this call review. So your system is a densely populated suburban area outside of a large city. It's a municipal system with transporting ambulance staff by 2 paramedics of similar skill and years of experience. So this isn't like a super 20-year-old provider and a brand new provider. These guys are fairly similar in years of experience. Your area hospitals, which we'll get into later. For now, I'm just going to say that one hospital is within 10 minutes and the other hospital is within 30 minutes. We'll get into why that's kind of cryptic later. Your ding.
Ding.
Dang.
I dinged myself, damn it. The initial
hate it when
dispatch,
that
I know.
That's illegal in some states.
You have a Delta response or priority 1 to a residence for a 70-year-old female altered mental status. Upon arrival, the EMS crew enters the home and is met by the patient's husband. He reports that about 90 minutes ago, his wife complained of a sudden onset headache. Severe enough, her vision became blurry and causing some dizziness, having almost fell while walking around the home. She felt as if she was getting a migraine, which he notes she does have a history of. She said that she took some Tylenol and then told her husband that she was going to sit in the living room for a while. He checked on her about 10 minutes ago. She's found to be slumped over on the couch, altered. This is when he requested EMS. The crew enters the living room and finds the elderly female seated on the couch, being propped up on the right side by a stack of pillows. Her eyes are open, but she does not appear to speak to EMS when they enter the room. What are your guys' initial thoughts here?
Not good.
Not good.
I mean, neuro. This screams neuro.
Okay. Screaming neuro.
Yeah.
I like it.
Yeah.
I'm not disagreeing there. I think this screams neuro as well.
I'll withhold judgment until we get a little further in, but yeah, I mean,
Yeah.
it's almost a neuro, like, path right down the rip.
Okay. Anything that you guys want to do right off the rip?
Yeah,
Other than just neuro, is there something specific that you guys want to do right off the rip? No, just go down the neuro path.
No,
I mean,
usual
I'm-
initial
yeah, you're-
assessment.
yeah.
ABC. I mean, always initial assessment.
Okay. You wanted to say something?
Oh, well, Gerard stole my thunder, so
I can
Okay.
edit it.
you just want to cut it all out.
Right back
It's
to it.
okay.
So these guys do initial initial assessment.
Ding.
The lead paramedic approaches the female and begins the assessment. They find her alert with her eyes open, but does not make eye contact. She does attempt to turn her head towards the providers, but only succeeds at certain times. When she does speak, she is only able to make sounds, no actual syllables or words. Airways clear, does not appear to be in any respiratory distress or difficulty breathing. Pupils are equal, reactive, and skin is warm, dry, and pink. The secondary paramedic, while all this is going on, they kind of tag team her. I know that sounds dirty.
Gerard,
Sorry.
that was your moment.
Stole that one right out from underneath you.
Start. I was like, what? Wait, what? That's on the tee. All I gotta do is
What?
swing.
Is that like gilf porn or something? I don't know. So
Wow.
So confused. Guys, my
Oh, so
dad
you're the one who
listens to
took the
this.
last copy of Naked Sorority Grandma 6, huh?
oh,
my God.
shit.
I finally put together what GILF means.
Yeah.
Good
for all
for
our
you.
listeners, enjoy yourself.
Well done,
with that one.
Kels. Well done.
So,
I'm proud of you.
Way to bring in the guilt reference.
I didn't even know that was a thing.
Oh, there's a lot of things out there.
There's a few.
There's a lot of things.
anyhow.
Not up in Germany, but a lot
So-
of things.
The secondary paramedic during this time connects her to the cardiac monitor and gathers a baseline set of vitals, right? These guys are fairly on top of things. The 4-lead EKG is connected and the initial rhythm is AFib, atrial fibrillation at a rate of 125, confirmed further by a 12-lead which showed AFib, no ST elevations or depressions. BP via the NIBP cuff, like the auto cuff, returns as 222 over 135. Respiratory rate 20, unlabored. Pulse ox is 90% on room air.
Can I get a blood sugar?
You can get a blood sugar, just not yet.
How was that thunder?
Put that on hold.
Wow.
I call bullshit.
Well, they eventually get it. It's just not there yet. Got to go through a few more bridges first. Other than blood sugar, do you guys want anything more specific? Like, where are your heads with these vital signs, this presentation?
I think it fits our initial
yeah.
thought. On
Still
this.
thinking neuro?
Yeah.
Yeah, the AFib at 125, meh.
Yeah.
Whatever.
It's not
That
really.
new?
I'm not
I mean, it's
jumping up and down. It could be
pinned in the back of my mind, but I'm not
Right.
really that concerned about it.
It's that BP. I'm actually going to believe that.
Okay.
I'm definitely taking another one, but that one right there, I kind of buy
Yep.
just based on what I've seen so far.
Okay. I like it. So these guys do go down the full on neuro assessment. They do a stroke assessment and they find negative facial droop. They see positive, slurred, incomprehensible speech. She is just sounds. Yes, Kelsey.
I have a question.
I was gonna say, if you don't say that phrase, I swear.
I know, I have a question.
It's the raising the hand thing.
Right.
Well, because otherwise he'll
That's a
just
sight
keep
gag.
talking.
This is radio.
Otherwise he'll keep talking, so I have to make it a point that I have a question.
Or you could just be like, Turek, shut
So
up.
I have a question.
Why is she propped up with pillows?
I am assuming that with my next sentence being negative weakness on the left side, right side, however, finds no purposeful movement or grip strength, that if she wasn't propped up on the right side, she would just fall over. Be like, timber.
So she has slurred speech, her pupils are equal, there's no facial droop, and she's right-sided neglect.
Correct. With a GCS of 12. These providers felt that she was a 4-2-6 on the GCS.
Now, did she have? You said she had a gaze, or she was just kind of like she would try to track them, but wasn't able to.
Correct.
Or, okay.
The whole head wasn't tracking according to what they were telling me. It wasn't so much like an eye gaze, like a pupillary gaze, or like up and to the right.
Was she
it
able
was
to cranial nerve follow fingers at all, or no?
She did not follow those commands. Okay. No. She tries to move her head and stuff, but
there was an attempt to, and you can see that it's just not happening.
Right.
Is her head stuck like to the right or the left per se?
I don't know.
Does it matter? If he said yes, would that change something for you? I'm just curious.
Well, because
where your head is.
They think they talk about if your eyes gaze one way, you're if you're having a stroke per se, and your eyes gaze to the left, generally your bleed would be to the left. I didn't know if it was the same thing for your head. Head just gets stuck
Or would it also confirm just that right-sided weakness?
I was gonna say I wouldn't even care.
It's an interesting direction. I don't know the actual answer, but yeah,
it
really doesn't much matter.
You look to your bleed.
Right.
So I don't know if with your head.
Is it stuck to the same side?
Stuck?
Yeah.
Right. Interesting.
Yeah, like your head follows your eyes.
Yeah.
Yeah.
I mean, I've definitely seen patients going back in the Wayback Machine. I've seen patients when they gaze, their head kind of tilts up with it. But I mean, I've never seen someone full on look over their left shoulder.
Stuck.
It's kind of they kind of trail up to 10 o'clock or 2 o'clock or something like that.
Right.
Got it.
But never I'm going to look at 9, kind of thing. So at this point, the secondary medic places her on 2 liters oxygen via nasal cannula due to those oxygen saturations around 90.
Oh, totally missed that. I was like, oh, for funsies?
Yeah, I was thinking about that too. I'm like,
I didn't even catch that.
Initial oxygen saturations on room air were 90%. This crew decided 2 liters was enough, which they were. Oxygen saturations increased to 98%. They also obtained a Kelsey, a blood glucose. It was 190 milligrams per deciliter. They also, for whatever shits and giggles, I guess in the age of COVID, because this happened at some point last year, they took an infrared forehead temperature, came back as 98 degrees. Cool.
I'm convinced
that
those
first infrared temperature that ever came back is 98.
I was going to say 97.7. Every single one is 97.7.
I'm convinced that they just pick a number. That those things
they're probably just random number generators. Yeah,
right. You just click it and it just gives you a new number.
It's like the NIBB cuff. It's just a random number generator. Oh, I throw my slots and boom, 3 numbers pop up.
Okay, your slot's not counting. One question.
Okay, is it pull slots? Sorry, pull slots, not throw slots.
You don't throw slots.
Exactly. That's what I said. You throw a slot and you pull it. Never mind. Carry on. I was trying to correct myself, but I failed miserably. Just go ahead.
Does that qualify as a dig?
Just to round out everything.
Qualifies me as an idiot sometimes.
not that I'm thinking we're going to find anything too far off, but lung sounds were taken at all?
Lung sounds were not taken.
Okay.
Not taken. Okay. But with this, I would assume...
Wait, can I ask what?
Just to cover all my bases.
Because they were hypoxic.
And really, lung sounds should be taken on every patient, whether the need be or not. So I like
you know what you're listening for.
Right.
And Lord knows we've
Please
had
listen to your
patients
lung
with
sounds.
more than one thing going on at one time.
God forbid that happens.
What?
Yeah. God forbid that happens. So during this time, the primary medic attempts to gather patient history and meds from the husband. Meds list as aspirin, simvastatin, losartan, Plavix, and hydrochlorothiazide, right?
We got a little HTN going.
Allergies.
HTN. Oh.
Hypertension.
Yeah.
You couldn't just say that.
No, it's funner to use acronyms. It's more fun.
Oh my God.
It's funner.
Abbreviations again.
Yeah. Allergies, Percocet, whatever, who cares? History, hypertension, hyperlipidemia.
HTN.
Please,
sir.
HTN, sorry.
What does that make hyperlipidemia?
High cholesterol, that's what that is. That's what I write. High cholesterol. Take that chart. And the husband notes that she does have a history of recent heart surgery, but does not recall what kind it was.
I was just going to say, why is she on Plavix? Because that's not one you go on for AFib.
Right. Another set of vital signs are taken at this time. The auto BP returns as 200 over 119. Heart rate is 127, still AFib on the monitor. Respiratory rate remains unlabored at a rate of 20. And the SpO2 now is 99% on the 2 liters. So your guys' thoughts, diagnoses, what kind of things are mulling over in your head here?
What was the surgery?
He does not recall when, or he said it's recent, but they don't have a specific day. Like they can't say it's been a week, 2 weeks, 4 days.
He's been taking all her meds?
According to...
But she's at such a high risk with the hyperlipidemia, the hypertension, recent surgery, the AFib. Even if she's on Plavix, she has so many risk factors.
Yeah.
Even if she's taking her meds, she's still at a high risk for a
Okay.
clot.
So you're thinking maybe stroke type, like a blockage somewhere in the brain?
So,
Okay. Ischemic type stroke. I like it. Kelsey, anything to add? Are you on the bandwagon?
I'm on the bandwagon.
She is on the bandwagon. So the crew decides, let's extricate her from the house, get her starting to move, right? Place her on the stair chair, get her onto the stretcher outside, then move her into the ambulance.
She was able to go on the stair chair?
Yep. I mean, with 2 shoulder straps, I could assume that she wouldn't be leaning too far. I mean,
What
I've
about
done
that
it.
head that's just like...
I can't even put a drunk person on a stair chair because they fall out of it.
Oh, no.
I'm impressed. I have faith in them.
Yeah.
I don't know who this is, but well done.
There were a lot of things that were
they are doing
fairly
great.
well done. Like, a dual paramedic crew. I assume this is a high volume agency outside of a large city. Like, good number of years of experience. Probably have seen stuff like this before. So once they get in the ambulance, the 2 paramedics kind of have a conversation about where they're going, right? That hospital 10 minutes away, that hospital 30 minutes away. And they agree that they both want to transport to the hospital that's 30 minutes away instead of the one that's 10 minutes away. And ultimately, they believe that that one is a more appropriate facility because these guys are also going on that this is some sort of neurological event and it could be a stroke. So they want to go to the comprehensive stroke center, whereas the one 10 minutes away is only a primary stroke center. So I kind of wanted to just go into like what each can do, right? So primary, typically they're not going to be able to deal with bleeds. So if you believe that this could be some sort of hemorrhagic stroke and you have a comprehensive like center close, just bypass that primary and go right to that comprehensive. But primary still can give TPA. They can still do CT scans and stuff like that.
That's really it.
And that's really it. Like they can diagnose what kind, if it's a blockage, they can start the TPA if they fit that parameter window.
And quite frankly, a lot of times when you have a clot, they're not going to catch it on a CTA as much.
Yeah.
So you really need to go to the comprehensive because even if it is a clot or an ischemic stroke, there's more options that they can do. Like, all right, that's great that this community hospital can give TPA. I'm not taking away from that, but that is a very small population that can actually get TPA.
Right. Most people, like the way it seems in EMS is everyone goes, oh, well, they have a block, they can get TPA.
Yeah, that's not the case.
That is not the case. There is a significant checklist that they need to fit.
And actually, she's a recent cardiac surgery, so she's not a candidate for TPA. So the primary stroke center is not going to do anything for her.
Right. They're going to transfer her out to the comprehensive anyway.
So just get her there.
Just get her there.
Time is tissue.
That's usually my thought process. Anyone that I have any inkling that it's going to be stroke related, anything like that, I just want to go to the place where I know they're going to get the best care.
And she's still within that window.
And the best options.
Like,
right, all the options. You got vascular, you got everything.
Yeah,
there.
she's still
I mean,
within the window.
90 minutes plus the time that EMS has been there. So, rounded off to she's been there for 2 hours with symptoms. She's still well within the
Even
window
on a 30-minute
to make
transport,
a 30-minute drive.
Exactly. And that gives her a lot of options.
Right. Do you guys, consensus at the table is they made the appropriate decision.
Absolutely.
I 100% agree. So they start transport to the comprehensive stroke center. And while en route, IV is established. The medic places a 20 in the left hand. I like bigger, but whatever.
You're going to put a 20, put it up higher.
Seriously. And that's kind of
but
like
the largest you can get. Like, go for the 18s. Don't be so afraid.
Well, especially in like strokes and traumas.
Yeah,
Like
the bigger the better.
The bigger the better. Most of the time, like
adult 18.
Yeah.
Pediatric 20.
You see, I don't typically follow that rule. Like if it's just like toe pain and I'm going to do an IV because they need something, right? I'll do a 20 because that's all they need, right? But if it's this or a trauma or someone that I need to make sure that I'm dumping a lot of stuff into or whatever, 18 at the smallest.
Yeah.
I
agree. Like strokes, traumas is like 18, 16, 14 if you can get it.
Yep.
I mean, like, I don't know. I don't put a lot of 20s in. I'm not gonna lie.
Well, and that's it. I think it's a lot of personal comfort level.
All my hospital people are laughing at me right now.
Why?
For the not putting the 20 thing in. They make fun of me for it all the time.
Well, whatever.
See, I get nurses that go like this, with a little heart sign when I tell them I have an 18 in all the time.
I mean, most
That's because you get EMS and they're like, well, we're going to call a stroke alert on this, but don't worry, they have a 22 in their hand.
Right,
what the fuck do you want me to do with that?
Yeah.
Just save the vessel. I'll get it later.
Even with the old, the geriatrics, I'll try an 18 first. If I get it,
bless.
Right on. If I don't, all right, now we'll look at some other options.
Yep.
But I mean, I want to give them the best, possible I can give them, and to me, it's an 18. I'm going to be able to bowl stuff in there and do whatever I got to do.
Yep. So these guys place 20, whatever.
At least they have access.
At least they have access, right? And usable access, right? Here's where they did something that I'm kind of like, okay, I see it, but I personally would not do this. They end up hanging 1,000 bag of saline and starting a maintenance drip of like a KVO drip. I don't really see the need for that. We can go into that later if you guys want to, but
that's like old school.
I don't really see the need. I don't see the need for it.
I used to do that.
Old school.
I have since gone into the saline lock it off, and
and that's like me. You get fluid if you need fluid. Like here, your pressure's already 220. Like what do I need to give you a little bit more for?
Yeah.
So vital signs again. 186 over 96. So we're coming down a little bit, right? Heart rate, 111, still AFib. Respiratory rate, 18, unlabored. SpO2, 96%.
So I have a really, really random question that I feel like is going to make me...
Join the club.
I sound stupid all the time.
So stroke patient, if they don't have reduced circulation, so should you not be doing an IV in whatever side their weakness is? Like if their capillary refill, let's say, is still the same.
So
you still have strong pulses on each. Still be cautious to do an IV on the functional side.
Right ahead.
I'm gonna say you should try and avoid the neglect side because that side is already at high risk for injury. They can't control it. If that were to infiltrate or anything, they can't tell you. She can't really communicate at all right now. But I always think of that as like a limb alert side. So I will, given the option, try and go on the non-neglect side. They're able to protect it more usually. They can feel when something's wrong without it dumping 1,000 bag into their soft tissue. I will say stay away from the neglect side. However, in the event of emergency, you get access where you get access.
Yeah. I like it. I'd go with that. I don't see anything wrong with them going in the left, the non-affected side. I think that's fine.
Yeah.
So getting back to vital signs, SpO2 remains 96% on that 2 liters. And they actually decide to do end tidal via a nasal probe. They just connect. They kind of switch out the nasal prongs for the, nasal cannula, and they use the nasal probe. And that returns as 41, an end tidal of 41. GCS is remaining 12. So not really seeing anything that's like jumping out at me here, but no neurological symptoms are getting better. Like nothing's getting worse, but nothing's really getting better. Right? We kind of agree on that.
At this point, I don't think I would expect it to.
Yeah.
Right. Like these are symptoms that are a little bit more than TIA-like symptoms to me. Like it's not screaming, oh, these might go away kind of thing. So approximately 10 minutes goes by in the transport when she shows tonic-clonic seizure-like activity lasting approximately 40 seconds.
Well, damn.
The primary medic... The primary medic...
Was this one of my calls?
No.
This is when I look from the driver's seat. I'm like, man, that sucks.
Yeah. So the
This
primary...
sure sounds like something that happened to me.
Like something that would happen to you.
It totally does.
Shit.
Yeah. So the primary medic ding sees this activity,
I missed
but
it.
there is not enough time to fully draw up and administer. Their protocol uses Versed, so 5 milligrams of IV Versed. Right? They get it drawn up, but they're just not able to give it before the seizure stops. However, this medic just kind of pockets it and says, maybe if they had one, they'll have
They'll
two.
have another one.
I
Right?
have a fun fact. 9.3% of all people who experience strokes will have a seizure.
Ooh.
9.3%.
That's interesting.
9.3%.
I did not know that.
That is interesting.
So they pocket that first dose of Versed, and when they look up from drawing that dose, the patient has not yet come out of the postictal unresponsive period. They check her responsiveness and find that she is completely unresponsive to all stimuli. However, the
Great.
respiratory rate
Where's that
remains.
airway?
Well, the
Gerard,
respiratory
we need to do
rate
this call together.
remains 14. She's still unlabored. SpO2 is 94. And end tidal,
On 2 liters.
stays the same at 41. They rerun the blood pressure. It's now 181/93. She's still at a rate of 120, AFib on the monitor.
Apparently that seizure did her blood pressure.
220,
220
220
on 119 or something.
Is it a fluke or is it like the seizure did her blood pressure
I'm
great?
just going to go ahead and...
I mean, great. Isn't she still 186? Isn't that what
She's
you just said?
181 right now.
Yeah, I still don't like it.
I don't like it, but I'm also looking
She's
at...
postictal, though.
Right, but we're also trending rapidly
Downwards.
downward.
Okay.
If we started up, remember our first, 2 or 3 BBs were like
220 to 180.
Yeah, I mean, we're
What's her heart rate?
in how long?
120.
It's dropping pretty quick, right?
Yeah, so the
20
initial
points
hold on, the
and-
initial blood pressure is 222/135. Now she's 181. Hold on, let's see, 181/93.
In how many minutes?
So she's had a 40-point change in her systolic and about the same in her diastolic.
in how many minutes?
15 probably.
This is probably
Mm,
going on
20.
35, 40-ish.
Oh, really? Oh, okay. I thought we were like 10 minutes, 5.
No,
10,
this is
15
10
minutes.
Well, they
minutes
got
in
him out
transport.
and they got her out of the house. The
Right.
assessor
Yeah,
got her
true.
out of the house.
Yeah.
So you have to think 20 minutes
20
on
and then
scene.
10 in
Yeah.
transport. so
10 in
30.
transport, so about 30 minutes ish. I don't know for sure, but that's just what I'm going to say. So the medic at this
And
point,
she's got fluids going already. So you can actually kind of play with that a little.
I mean, they're KVO fluids, and they don't.
You can,
Yeah, but this crew decides not to change the fluids.
I would not.
at all.
I would not
no,
either.
They just-
no.
They're just there.
I'm just saying it's. I don't know. I'm not really worried about that. It's still too high, and she's postictal. So
Okay. So the medic looks at her and goes, I don't really like where this is going. So he actually decides to put in an NPA. Left
Nice.
nair, completely successful, takes it like a champ.
bilateral.
No,
Is that what you said?
no, absolutely not. So are you guys kind of okay with everything that this crew is doing so far? Like
Yes.
they're pretty on the ball,
Yeah.
right? You're still going down the neuro train here, I would assume. So the crew is still about a 15-minute drive from the hospital. The medic delivers an incoming radio report declaring a code stroke, right? Code
Bless.
neuro, right?
Kill them.
Agree? Disagree?
Yes.
Yeah.
Yep.
Absolutely, right? When the medic hangs up the radio, she begins to seize again, showing again tonic-clonic activity. The medic administered that pocketed 5 milligrams IV Versed.
Good man.
Awesome.
Or
Good
woman.
man.
Yeah. However, the seizure lasts another 2 minutes after the IV dose before stopping. She remains unresponsive, and at this point, ventilations decrease to the point of agonal breaths.
Now we got like
Fuck
2
me.
out of 3 of Cushing's triad.
Okay? Very interesting. Your guys are looking at me like this is getting bad.
I'm hating this patient right now.
How dare she have a medical emergency?
Yeah.
The nerve of her.
Yeah, seriously.
Dare she get sick?
Right. Ouch.
You're sure.
I mean, it's funny.
No. No, me. You got to do all this crap.
You gotta go above and beyond.
So at this point in time, like, what's going through your head? Before I tell you what this crew decides to do, what's kind of going, like, what would you do in this situation?
Secure the airway. And
Yeah,
take over
I mean,
ventilation.
when she says the first time, Gerard and I looked at each other for airway, but
Yeah.
Okay.
I would go a little further.
Okay. So are we talking RSI? Are we talking like intubation? Are we talking BVM? What are we doing
At this
here?
point, we've already given radio report. How far out are we?
15 minutes.
King, go.
Ooh. Interesting.
I
Okay.
appreciate that.
Digitally or non-digitally?
Do it Ronnie style, face to face fish hook.
I like it. So this medic actually yells up to his partner, stop, pull over. We're going to RSI this patient right here. Are you guys okay with that?
No. I think now you were ahead of the curve.
Okay.
Right until that point, you make that decision, and now you're stopping getting her where she needs to go.
But is that going to make a difference if there's no airway?
But at the same point, like, I see the point
I
in a
see where
king
you're-
airway. However,
Yeah.
if you can take
She's unresponsive.
5-10
correct?
minutes with agonal breaths, like, she needs an airway.
I don't think I disagree with that.
And the proper airway is intubation, like an ET intubation. Yes, a king would do it, but is it proper?
Gold standard, of course, is ET intubation.
Right. I don't disagree with this move.
I don't disagree with it either.
Like, if this was, they were 5 hours out or 4, they're crushing time, like they got 4:45 or 3:45 in the 4-hour
But even
window.
if they are, they're going to take the time to secure the airway before anything happens
Exactly.
anyways. They're going to take this time, whether it's in the ambulance or in the hospital. That airway is going to get secured before the interventions get done for the stroke. So
and you can't bag someone in a CT scanner.
right. So take the 5 minutes. I don't disagree with them.
Yeah. I think
Actually,
I
think I would do it too
I probably would have done this too.
from the driver's seat.
Yeah. anything to you're mulling it over still. I see
I'm
it.
still mulling it because
I mean, I like the king idea.
I'm just thinking right now we've made so much headway ahead of that curve, and I think stopping to do an RSI, although thankfully we've got 2 medics and we actually have the option to do that.
Mm-hmm.
I mean, if she's completely unresponsive and she has no gag reflex, absolutely. I think a king, secure it, verify that, make sure we have.
But you're not going to
everything
put the
in place.
king on a vent. So she still needs to get intubated before she can even go to CAT scan. You're going to lose this 10 minutes
And she's gonna
regardless
lose
of
on
where
the
you
other
are.
end anyway.
Right.
Yeah, you're right.
Just
You're
where
going to
she
lose the
loses
10
it.
minutes. Are you going to lose it in the ambulance? You're going to lose it in the ER.
Yeah, true. But then again, I mean, no. Would I rather have it, lost with an RT in a nice stable setting with, all
No,
the,
I'd rather take
the
the
safety
airway,
nets.
walk in, and walk right to CAT scan.
Yeah. All right.
All right.
I can see it.
So
I mean,
Agree to disagree.
no.
No, both points are
I don't
good.
disagree at all.
I think it's just a preference.
This is one of those things where if you really had to be, I guess you really have to be in that situation.
right.
Because it's easy for me to sit here and go, yep, fuck it, throw a king in.
Yeah.
And it's easy to say, oh, no,
It's
do the
easy to
fucking RSI.
quarterback
Well,
the situation.
Yeah, oh, yeah.
Yep.
We're not making these, split-second decisions, in the rig right now. We're around a table. We've got drinks. We're, happy.
So these paramedics do agree to RSI as she can no longer protect her own airway, and she's remained unconscious, unresponsive after the
I
seizures.
mean, you
Right.
got to do something. Yeah.
Exactly. They begin to assist ventilations with the bag valve mask. They hook that up to 15 liters oxygen, and they provide a rate of around 14 breaths a minute. They also start high flow passive oxygenation through the nasal end tidal probe. which I think is cool.
Nice.
Right? Not even nasal prongs like nasal cannula. Let's just use the end title.
Yeah.
I like it. And they still have that NPA in.
Yeah, work with
right?
what you got.
Work with what you got. They run vital signs prior to the med admins, which I think is awesome. We should all be doing that.
Yes.
Blood pressure, 141/89.
Oh, fuck.
Yeah. Heart rate is 119. Now it's a sinus tach on the monitor. It's no longer an AFib. SpO2 is 92%, end title's 46. They actually repeat a BG, which I think is awesome after the seizures. And it was 190. Now it is 69 milligrams per deciliter, which I think is a serious change.
Yeah.
But it's just really interesting that they chose to do that because most providers would not think to
Your body just
recheck.
chewed up all that glucose.
Right. They
I find it interesting she's also not a diabetic and her initial trigger was 190.
seriously, right?
But I digress.
Yeah. That's an interesting point. I didn't even notice that. Didn't give it a second thought. I was like, oh, 190, okay. When I was reading this.
It didn't say hi.
Right. With
Moving
ketones. So the medics choose to intubate with etomidate and succinylcholine. The primary medic sets up the intubation equipment. Don't even start. I do not understand or know why they chose sucks over. They might not have had anything else.
I can tell you why.
I honestly don't know because that's what we always do.
They
Sucks.
No, I
were they
have asked-
reading that same study?
I have asked so many people, like, why'd you choose sucks? It's easier to dose. Okay.
Okay. I don't know the answer.
I know.
I don't know the answer. So they choose etomidate. They choose sucks. They
People don't like doing finger math.
probably. As we teach for BVM, Gerard, they actually position this lady's head at 30 degrees
Nice.
up. And I was like,
Hey.
so wing.
Right on.
So when they reposition the head, the primary medic who's setting up for the intubation finds a bandage to the left side of the neck.
Was it wet?
No, it's not a wet bandage. It is dry.
That was relevant on the last one.
It was. It is dry with no signs of discharge, right?
On the left neck?
On the left side of the neck. Now, from what I know, talking to these providers, this was during the colder sets of months, and there was a turtleneck. And when they repositioned her head, they could actually move the turtleneck, and that's where they saw the bandage. So it wasn't like they saw it from, day one. Like, boom, there it is, staring at you. It
Wait,
was
so
covered.
like a Band-Aid?
No.
Or just like a...
Like a 4x4.
A 4x4.
Or like a huge surgical, or like not a huge, because if it hides by the turtleneck, but like a surgical dressing?
Yeah, like,
A 4x4?
I don't know. It just says bandage. Okay. That's what you're going on. Wet, dry. It's dry, but
At
whatever.
least it's not wet.
At least
I would have not been able to move forward
You're still stuck on
if there was
it.
another wet bandage.
seriously.
What are the odds?
What are the odds, right? The second medic, while the primary medic is setting up all the intubation equipment, actually takes the time to not only get the dosages of the meds, but also start another line. They start a 18 gauge in the left AC.
There we go.
And yeah, you just needed the right medic. That's all.
You needed the driver.
Right. You just needed the driver. She is successfully sedated, then paralyzed, then intubated on the first pass with a 7.5 ET tube.
Go with the 8.
Placements confirmed. Who knows? I'm not even gonna.
No,
that's a
I'm
judgment call.
totally joking.
Like, whatever. Placement is confirmed via waveform capnography. They do listen to lung sounds at that point in time. They're clear.
Excellent.
Cool. So they begin transport. Secondary medic goes back up, starts driving wee-woo bus to hospital. Now, remember, 15 minutes away. To the boo-boo station. Right? During this time, she's continued to be ventilated by the BVM. She's given one more dose of 5 milligrams Versed for post-intubation sedation.
I was just going to ask, what are they using today's? Because, yes.
Yep. And the last set of vital signs before they give over patient care is BP 155/79, heart rate still sinus tach 122, SpO2 is 99%, end title of 46. They arrive at the ER. Cool. They hand her over. Awesome. Your guys,
Please tell me I can find out what the bandage on the neck was from.
your guys' thoughts
No.
and stuff with the whole call.
I think
Before
they
I
did
go
a great
into
job.
Yeah, I think spot on. I think the only thing I would have maybe considered, seeing that huge drop in BG, I probably might have throw some D10 in there.
Okay.
But that's about it. I think everything else was pretty much spot on.
Okay. So do you guys want to know what happened?
Do I get to know what happens to what is the bandage from?
What's the bandage for?
Please.
You don't get to know what the bandage
Okay,
is.
then I want to know what happened.
Yet.
Oh, keep going.
So when they arrive at the ER, they go in, and the ER staff right there on the stretcher did deem her a code stroke at the door. They said, "Yep, yeah, she's gorked. CT.
Go to CAT scan.
Right, go to CAT scan."
Which they can do because she's intubated.
Right.
Ooh,
Burn.
dig.
Burn.
So she is sent to the CT, where they confirm via CT there are no blockages, no bleeds, no significant signs, no signs at all of intracranial stroke.
UTI.
You're either having a stroke or you're septic. Does she have cancer?
She does not have cancer. There is nothing wrong with her head. Nothing.
No.
Okay, hold on.
No.
Nothing wrong. That CT is clearer than clear. There is no.
No, I needed an
tumors.
emergent MRI. I
There's
don't believe it.
nothing.
I don't believe
Nothing.
it.
She's
That's
denying
impossible.
results. You've just now postured into your thinking pose like, I'm now
So
going to
she
debate
has-
this.
This also
So she-
my pray to God post. Please don't let this person on me.
It's
So
not on you
she's-
anymore.
That's true.
History of
Not my
migraines,
problem.
hypertension, had a headache, altered mental status, and now she has new onset seizures, and it just all happened in the same day.
Yeah. Apparently.
Did she? No,
Did
because
she-
I was gonna say, did she fall?
No, because she didn't have a bleed.
No, right? Yeah. UTI.
Doubling down.
Doubling down
Yahtzee on UTI.
with a wet bandage.
All right.
God damn the bandage.
So,
Well, actually, no. Why would the bandage plays a part in this? I'm telling you.
I mean, they don't rotor you through the side like that. I mean, what the hell happened?
a bandage.
Biopsy.
A biopsy? Interesting
Would you
theory.
grow
Did they
second
fuck with her
head?
thyroid?
Throw a second.
Is it a
COVID
hormone
vaccine
thing?
And grew a second head.
Whoa.
Tinfoil.
So these doctors see this and go, what the fuck, right? We're sitting here looking for...
I think the whole hospital just said, "What the fuck?"
Right,
Wait,
like,
There's
what
patients in
the
triage.
So they notice now the bandage and they go, what the fuck is this bandage for? Right? Bandage plays a key part.
Ding.
The bandage does play a key part.
Every time.
right? So they
Every time.
they do
It probably says, "What the fuck?" under the bandage.
seriously like
Joke's on you, bitch.
yeah, right. So because of this bandage, for whatever reason, the neurologist in the CT room decides to do a CT of the neck, where they find a 100% occlusion to the right carotid artery.
Okay,
she-
so I mean, it's still an ischemic
yeah.
neuro event.
Exactly.
Stroke in your neck.
It's a stroke in your neck.
Yeah.
However, we have to we have to go back in the call and think that that husband said she had a cardiac procedure done, right? He was misleading in that this wasn't really a cardiac surgery that she had a vascular surgery. So
They did roto-rooter.
so they did roto-rooter that the
Carotid.
left carotid.
They go.
That's what I was thinking.
I didn't think that they went
think they
right
went
there
straight
for
there,
it.
yeah.
Yeah. I don't know. I don't work vascular.
Apparently, this hospital, wherever she went and got it done, did do
Yeah,
it
I'm
that
Wait,
way.
so they did that recently and she re-occluded?
2 weeks. No,
That
so
was the Plavix.
no, so
That's what she was
2
on
weeks.
it, yeah.
So the updates that I've gotten from this crew is 2 weeks prior to this event, she had the roto-rooter done on the left side. They then noticed that she had the occlusion on the right side. So she was occluded on the left. They dealt with that. They were probably, I'm assuming, going to deal with the occlusion on the right. And then, boom, she tossed a clot, had that 100% occluded.
Which makes sense because she's got every single risk factor.
Right.
Wow.
So
God, what the fuck are the chances of that?
Wow.
Seriously. It's just, like, this call to me was just so cool because you're expecting exactly what you guys were expecting. Like, you see neuro, it's caused by neuro, it's a bleed, it's a blockage.
Right.
We're going with that.
Technically, we weren't wrong.
You're not wrong.
And the crew was definitely not wrong in there.
It's just where it was.
It's just
That's
where
so
it was.
It's like how
interesting.
an MI is a stroke for your heart. This is just a stroke for her neck.
But it's still affecting her brain.
Yeah.
Right.
Like, you're
Because
still having a stroke. It's in it. Your brain is.
lack of perfusion.
Yeah,
like
ischemic.
there is lack of perfusion, and that's what's causing all of these deficits, right? When we think like strokes, you get that lack of oxygen and perfusion from either lack of blood flow because of a clot, or you get it because the blood is leaking out to other places in the brain cavity, and it's not actually getting to where it needs to go. It's still all lack of perfusion. It's just happening from a completely different
everything
site.
south of the clot is still functioning normally.
Functioning normally.
Like nothing happened, right?
Yep. And the blood pressure is trying to overcome that blockage, thinking I need to get extra pressure to push the brain.
Which is why it's so high.
Which is why it's so high initially, but the brain is clear. So it was just, I thought it was something.
And there's where all that
Which
glucose
actually
went.
shows how well her body did compensating during that entire time.
Yep. I agree. I thought it was just a really interesting call. Even though it's very cut and dry on what it was.
You know what that sounds
it's just
like?
really
is
interesting.
One of your scenarios in school.
Seriously.
That's that 190 on the glucose. She had the insult and her body just went, boom, here you go.
I need to fix this.
Yep.
I need to fix it.
That's what I'm saying. It actually shows how well her body compensated for it at 70, whatever she was.
It's like, wow.
Yeah.
That's pretty cool.
Yep.
Yeah.
And this
That's
crew,
why you should always get hospital follow-up.
Yeah, I agree. And like we said, this crew did everything spot on.
Yes,
I agree with every decision that they made. They were phenomenal.
Yeah.
Phenomenal. We can't really bash them all that
I wouldn't
all that hard.
at all. No.
Yep.
Nope.
I like it. So, anything else, guys, before we wrap up?
Cool call.
That was a good one.
That was a good
interesting.
Yeah.
Mm-hmm. Kelsey smiling over
And
here.
the goddamn bandage.
I'm just going to keep finding calls.
I swear.
That
with
bandages.
Hey, all you people out there that have interesting calls involving bandages, send
them
them
in.
Send them in. Yep.
Every time.
Every time. Like, I think I'm going to start putting bandages in for no reason. Why do they have a bandage on their penis? I don't know. I just felt like putting it in there.
No, because the last two were relevant.
It's a UTI. All right, guys.
Fix UTIs with bandages.
Seriously.
So help me God.
All right, guys. Till next time, stay safe.
Donuts.
Thank you for listening to today's episode. If you'd like more information on the podcast or to send us a call to review, visit medicmaterials.com/podcast. To learn more information, like us on Facebook at Medic Materials EDU, or watch our weekly instructional videos on the Medic Materials YouTube channel.